the approach is, if your ketone is low or absent, look at reducing substance. If it's positive, it is galactosemia or fructose intolerance. Negative and insulin is undetectable, think of a fatty acid oxidation defect. If it's detectable, it is hyperinsulinism. If ketone is high, look at lactate level. High lactate means GSD1 and gluconeogenic defect. Do a glucagon test in a fed state. If it's normal, look for organomegaly. If it's present, is GSD 3, 6 or 9. If it's absent, you do cortisol and GH. Low level suggests hypopituitarism. A normal level is likely suggestive of a accelerated starvation. So the most important investigation is ketone followed by reducing substance if it's a hypoketotic, and lactate if it is a ketotic hypoglycemia. Now, hyperinsulinism is a different ballgame altogether, and it is the most common persistent cause of hypoglycemia in the newborn period. So first of all, you have to exclude the transient causes like infant or diabetic mother, prematurity, all those things, drugs, and then you do a trial of diazoxide. If you have improvement, then you continue with that. If, however, there is no improvement and diazoxide response is there, don't worry, you continue on that. Don't do unnecessarily genetic workup or imaging. In this scenario, you can check ammonia level for GDH, which will help you the diagnosis. If the diazoxide response is absent, this is a very important recommendation that you should do a genetic study of the child as well as both the parents. So if you have a paternally inherited potassium ATP channel defect, it may suggest a possibility that this is most likely a focal disease, and then you can do a fluorodopa PET. However, if you have a recessive defect, it is not going to be focal, it has to be diffuse, and you have to consider surgery in that regards. If, however, you have got no defect on genetics and there is Beckwith-Wiedemann syndrome, then you can do a imaging, because Beckwith-Wiedemann may also have a focal form in that regards. So the most important part here is diazoxide responsiveness, and we'll talk about what do we mean by that, and then genetic study for the potassium ATP channel defect in non-responsive individual. So Dhwani, 3-week-old boy with seizure, sugar is 28, ketone is 2.3. What will you do now? So lactate level is 1.2, there is hyponatremia. What are we looking at? Yes. So hyponatremia. Any pointer? Hyponatremia with hypoglycemia. So we have to look at other scenarios. So there is a micropenis. So this is classically a case of a central multiple pituitary hormone deficiency. But the cortisol and growth hormone are normal. Why do you say that this could be a central problem? So cortisol should be at least 500, 550. Growth hormone should be more than 10. So look at the appropriate response to the level of stimulus and not just the normal range. So multiple pituitary hormone deficiency. 6-month-old boy with lethargy with hypoglycemia, ketone is 2.4. So what will you look at on examination first? So hepatomegaly, renomegaly, all those things. So there is hepatorenomegaly, both are present. So what do you expect in this scenario? So you have to look at lactate levels. So lactate levels are very, very high. So this is most likely GSD1 in that regards. 3-week-old boy with failure to thrive, blood sugar is 30, GIR is 6. So it's a physiological response. Would you evaluate this child? Response is only GI. Forget about hepatomegaly. He has a normal GIR and is responding. Do you need to evaluate for this hypoglycemia?
Definitely, so there are causes that are beyond hyperinsulinism.
So anybody who is beyond 48 hours, whatever the cause, whatever the GIR, you have to evaluate. So hepatomegaly is there, ketone is negative. So non-ketotic. So you know that the liver is more nodular, firm. You have to think of a galactosemia, the possibility. Reducing substance was positive, so this is galactosemia. 10-day-old girl with hypoglycemia, glucose infusion rate is 14. So this suggests that this is mostly an increased requirement state. Ketone is negative. Now what you see, reducing substance is negative. So what do you mean? Think.
Yeah, high.
So in this scenario, insulin is 3, which is normal. So again, don't consider this as normal. Any insulin, if it's present during hypoglycemia, suggests that there is hyperinsulinism, and you do a glucagon response was positive. 2-day-old girl with seizures, blood sugar is very, very low. Ketone is 0.1. Reducing substance is negative. Insulin is high. What are you thinking of?
But ketone is negative. Like this and reducing upset. So hyperinsulinism is.
So what would you like to do in terms of workup here and treatment?
In terms of workup, first we have to about the season, symptomatic management first, and then we have to check for what is the cause of this hyperinsulinism.
Yeah.
And we have to maternal history also, whether the baby was a last.
So there is macrosomia. So now you will do a maternal sugar as well. You will ask for that. So there is a maternal diabetes which is causing this. This is classical infant of diabetic mother. Usually by 5 to 7 days they will resolve. 14-day-old boy with birth asphyxia in the ICU has a hypoglycemia with a very high GIR. Ketone is negative. Insulin is detectable. Birth weight is 1.6. So what you're dealing with? It is not transient but prolonged hyperinsulinism. So what will you do now?
Do the history correction of hypoglycemia.
Yeah.
Then we'll give, if it does not, then we'll give a trial of diazoxide.
We have to give because he's very high. He's already on glucose. So he will need to have diazoxide because requirement is very high. So we have to give diazoxide and we confirm it. On follow-up, diazoxide 10 milligram per kg per day, not minute, reduced GIR, now develops weight gain and edema. So what are we thinking of? So what do you want to do before you start diazoxide generally? Platelets and ideally echo also to look at cardiac function, because diazoxide is basically what? It is a potassium channel opener. So it is an antihypertensive medication. It's like nicorandil, that sort of a group of medication basically. And by serendipity. So what happened? People used to say, okay, when you give diazoxide, it causes diabetes. So people thought, okay, if it causes diabetes, then we can maybe use it for hypoglycemia. So this is how, because everybody did, that time we didn't know about that much, about the mechanism of action, how our blood pressure, how potassium is going to affect the insulin secretion. So now this is very interesting. That started as antihypertensive and then it was used like that. Similarly, minoxidil as an agent was started for hypertension and it causes hypertrichosis. So people used to start using for hair fall. So these are the way serendipity. This is how the medications were developed earlier. So diazoxide induced, what will you do now? So thiazide will be preferred and then you can taper after up to 3 months. 10-day girl with hypoglycemia, glucose infusion 14, high, ketone negative, you reducing substances negative. So what are you looking at? Okay. So now you see insulin is 3 again. So this is classically a case of hyperinsulinism that is there. 3-day-old boy with severe hypoglycemia, birth weight 4600, GIR is 18, ketone is 0.8, insulin is 2.4.
So definitely, this is a LBW, more weight. So we have to take the history of mother.
So you have to think of large for gestational age. So you have to think of maternal. So maternal is absent. There is no maternal diabetes. HbA1c is normal. So then this could be a very severe early with macrosomia. Think of a mostly diazoxide unresponsive form, likely in that regards. So diazoxide was started.
In this diazoxide use, is the fluid retention present in all the cases, or there is
a tendency? So you have to look at the weight. Basically, it can happen to anybody. If you give a higher dose, there will be more chance.
Along with the
they can give it, so it's not a problem. So on follow-up, diazoxide was 10 milligram per kg, increased to 15. There is hypoglycemia, which was there. And then glucagon infusion was given. So basically what's happening is that he is not responding to diazoxide. So what will you think out here? Okay, so KATP defect, and you can go for genetics. And if genetics shows that there is a paternally inherited, basically heterozygous pattern, then you can go with a fluorodopa PET. So KATP defect has to be looked at. And then there are other options. Mostly it's a surgery, which is a palliative option. 10-day-old boy with hypoglycemia, birth weight is 3,400 grams. So what is less likely in this child? Which disorder is effectively excluded? But it is not high. So it's not likely to be a macrosomia scenario. So Beckwith-Wiedemann hyperinsulinism will be less likely. GIR is 13. Ketone is 1.2. So borderline. Insulin is 2.4. What will you think of? Okay, hyperinsulinism was diagnosed and then diazoxide was started. On follow-up, diazoxide 10 milligram, there was no improvement. There is hypoglycemia. So paternal potassium ATP defect was there. So what it is telling you, they have a milder form of hyperinsulinism as against the previous case, which Dhwani had discussed, was a very severe form, where you would need definitely surgery. But this is a paternal potassium ATP. So you can go ahead with a localization study. You can do a PET scan and found a focal lesion for which surgery was done. So this is a milder form where macrosomia is not essential in that scenario. 15-day-old girl with hypoglycemia, birth weight is 3,200, GIR is 14. So again, you're looking more likely to be increased utilization state. Ketone is borderline. Insulin is 3.2. So what will you do further? This is an older girl presenting a bit later, not macrosomic. Again, so it makes that most likely it's a hyperinsulinism, but seems to be a milder form. So yes, so diazoxide was started. On follow-up 10, clinical improvement, DHR came down, ammonia was 120. So this is a GDH or hyperinsulinemia, hyperammonemia syndrome. What treatment will you give for the ammonia? So this is basically normal. It is not going to cause any harm as far as the CNS is concerned. 21-day-old boy with recurrent hypoglycemia, birth weight 3,900 grams, GIR is 10, blood glucose is low, insulin at that time is undetectable, ketone is positive. Okay, insulin rise happens with higher sugar. So this is a very, very interesting scenario. So insulin was undetectable and ketone was positive, but when the sugar became slightly high, insulin then became present. Yes, so this is like GCK. So glucokinase defect basically, in which you have got a sensing issue. So it's just the opposite of monogenic diabetes because of GCK, where your sugars go up initially and then your insulin production pulls it down. Here again, till the time your glucose insulin is there, it will work, but after that time, it is a self-limiting disorder which is there. So this is a GCK defect, a difficult form. 12-month-old boy with recurrent hypoglycemia, non-ketotic, insulin is 3.2 after 6 to 8 hours of fasting. What are you looking at? Okay, worsened by protein intake. So whenever he has something heavy or something, he develops hypoglycemia. Insulin is detectable. So ammonia is normal. So this is a SCAD defect. So these are all which are responsive to SCAD, also interacts with the GDH pathway. But ammonia here becomes normal. 12-day-old boy with lethargy, glucose is very low, ketone is low, insulin was detectable during hypoglycemia, but a birth weight is high. Umbilical hernia and ear creep. So you have to look at hepatomegaly. And what is the course usually here? It is a resolving case, but what would you want to look for in future? Any risk? in future?
uh,
Tumors, neuroblastomas, all the cancers. So you have to be very, very careful for abdominal examination later on. So this was the 11p15 Beckwith-Wiedemann. On follow-up, diazoxide 5, glucose were persistently low, increased dose, fluorodopapet was done. So again, as I said, if it's Beckwith-Wiedemann, you have to again follow the same scenario and you find a focal lesion for which a surgery could be done. 2-month-old boy with developmental delay, persistent hypoglycemia with a high GIR, glucose is 27, ketone is negative. So what are you thinking of? Insulin is undetectable. But you have a persistent hypoglycemia with high GIR in fatty acid oxidation defect. So unlikely. There is a glucagon response. So now you have a 2-month-old child who had so much hypoglycemia, has already had developmental delay. He has non-ketotic hypoglycemia, which responds to glucagon, but insulin is undetectable. The two things, you can say that, okay, insulin may be undetectable in 20%, but let's say C-peptide is also low, everything is there. So what does it mean? Insulin is working, but it is not there. Resistance? Resistance will cause hyperglycemia. Why will it cause hypoglycemia? So what does it mean? Insulin is not there, but it's working. So 2 months mein which antibody? So LH is not there, but it is acting. TSH is not there, it's acting. So receptor or post-receptor problems. So this could be a AKT2 defect. So this is a very rare but interesting scenario in which your downstream pathway of insulin is working. So this is like GNAS1 defect, like McCune-Albright, like testotoxicosis, similar sort of a activating mutation, you can say. 14-year-old girl with recurrent hypoglycemia, now it's 14-year-old, 36 is the blood sugar, ketone is negative, insulin is 240. What do you think? Insulinoma. So how will you know it's insulinoma versus a more common cause? What is the other possibility? Insulin being so high. So insulin is high and it's acting. It means somebody might have given. So you can be, it could have been given from outside. So endogenous versus exogenous. You do C-peptide level. C-peptide is low. It means it's not insulinoma. It is exogenous. So classically, this is basically a regular insulin will cause high insulin with low C-peptide. So on hospitalization, we have seen these sort of patients, absolutely sugars are normal. And then if somebody takes a very careful history, under confidence, separately, they will tell, okay, they are using their mother's, grandmother's insulin. We have seen nursing staff also being admitted with a similar picture. So they have access to insulin. That will be the scenario. 16-year-old girl with hypoglycemia, glucose is 26, ketone is negative. Insulin is 320. Again, very high. Now, persistent in hospital. Now, what are you thinking? You are ensured that there is no insulin being given. Now, what is the likelihood?
Now we need to think of
Insulinoma. Anything else? It can have a longer thing, but many days there is no response. So anything else I'm asking about possibility? Okay. There was a rapid course. So if you have an autoimmune cause, we discussed there are two types of autoimmune hypoglycemia. One in which you have an antibody which is activating the insulin receptor. There you will have a persistent hypoglycemia, but the insulin will not be high. The other is where it sequesters. So it will take the insulin somewhere and then release at the wrong time. So that is the mechanism. 18-year-old boy with weight gain, recurrent hypoglycemia, ketone is mildly positive, insulin is 120. Now, no autoimmune cause, your C-peptide is also high, So now what you're thinking? And weight gain means that what does it mean? In a child with hypoglycemia, if they're gaining weight, what does it mean? Due to what? Sulfonylurea, it is persisting. So you think of insulinoma, the classical presentation is weight gain. So in this scenario, imagine